So ultraviolet UV radiation and its association with lupus and our dermatomyositis patients, it's well known to all of us. I think a brainstorming question that has been asked is, what about in rheumatoid, in psoriatic arthritis, in other autoimmune diseases? Also, like most of the data that is of the UV radiation and basic research papers are from the non-Asian continents. And we know that UV radiation is affected by multiple factors. The medium wavelength is the most hazardous, the 305 nanometer is the most hazardous. And UV radiation is different. It is higher in the north and southern poles, lesser at the equators. It is lesser in winter, more in summers because of the sun exposure. It is also affected by altitudes. The higher altitudes have different wavelengths, which is not as hazardous than the plains. So considering these factors, I think this is a real question, a research question that needs to be asked. We need to ask how much and to what extent is the association of UV radiation with other autoimmune diseases. So is it real or by chance? And I think this really needs to be studied with statistical data. And with this, I think we are leaving you all with this question. I think we can conclude this session.
So we conclude the session.
Thank you. We hope all would have a great time event, and we would like to extend gratitude for all speakers, delegates, honorable chairpersons who had spared their time to make this event successful. Thank you. Now we are moving to the next session, that is classic session on myositis. And now request Dr. Narendra Kumar Margi to come to the dais.
So good afternoon, everyone. And first, to begin with, I would like to thank organizers for giving me the opportunity to coordinate this session. And this is a very meticulously planned session classic session on myositis, and in which we'll be covering on the biomarkers, the role in their clinical use of biomarkers in myositis, and then we have the recent update on the classification and the management of myositis. Can we have the slides, please, for this? So just to introduce myself, I am Dr. Narendra Bagri, and I am Associate Professor in Pediatric Rheumatology at AIIMS, New Delhi. And for this session, I have seasoned team, and my chairpersons for this session are, I would like to invite them on the dais, Dr. Madhumita Priyadarshini Das, Professor of Medicine at Guwahati Medical College. Ma'am, please come on the dais. And to accompany her, I'd request Dr. Lisa Rajshekhar from Nizam's Institute, from the Department of Clinical Immunology and Rheumatology, Nizam Institute of Hyderabad. And I would also like to invite the speakers for the session, Dr. Anu Dabar, who is a senior consultant rheumatologist at Paras Hospital, Gurugram, and she will be enlightening us on the role of biomarkers. And the next speaker for the session is Dr. Vinita Shobha. She is from the Department of Clinical Immunology and Rheumatology at St. John's Medical College, Bangalore. And ma'am would be enlightening us on the 2022 myositis classification. And for the keynote lecture in this session, I would like to invite Dr. Ingrid Lundberg, the professor in the Division of Rheumatology and the Karolinska University Hospital, Stockholm, Sweden. And she will be enlightening us on the update on the session of management of myositis. Welcome, ma'am. So without wasting much time, I would like to invite the first speaker, Dr. Anu, to begin the session with an update on the role of biomarkers in the management of myositis. Over to you, Dr.
Anu. Good afternoon, everyone. So it's a great feeling because this is the city where I developed the interest to pursue rheumatology, the city where I did my MD medicine from the government college here. So we'll be talking about how do we follow a myositis patient in a daily clinical practice, which is quite different from the scenarios we read in our clinical trials. And let's move on. So I'll be talking about biomarkers which we can use to monitor disease. And here I'd like to specify that biomarker need not always be a biological macromolecule. It could very well be a physiological parameter, as you'll see in the subsequent slides, which should be objectively measurable, and it should serve as an indicator of a pathogenic pathway. Now, because we're talking about follow-up, we'll be focusing on longitudinal and pharmacodynamic biomarkers, which should fulfill important criteria of sensitivity and specificity. So when we talk about approaches for assessment, we move on from muscle enzymes to muscle testing and several dynamic muscle assessments. To start off, we commonly use MMT-8 in our clinical practice because it's the abbreviated, validated version of manual muscle testing, and it uses 8 muscle groups, which we'll subsequently see. There are also certain dynamic muscle assessments which have of late been used to assess physical strength and endurance, especially timed walk test, time to rise from a chair, and timed walking of a particular distance, and testing using weights, especially like lower weights like 1 kilogram. And then, so this is the commonly used MMT-8 which we use, and it uses the 10-point Kendall scale, and it tests these muscles which I've listed here in the order mentioned. And it helps us quantify what is the level of muscle strength in the patient, an important parameter which we assess. And it's been validated very well in patients both for adult and juvenile myositis right back in 2010. And it meets most criteria such as inter-rater, reliability, convergent validities, and a correlation with several other parameters like physician parameter, muscle enzymes, and MMT-24. This is another interesting paper which was published from our center, my institute DM, where I did my DM from, that is JIPMER. And here they've tried to assess or correlate what is the correlation between a timed function test, such as a 2-minute walk test and get up and go test and using weights. And what they've really seen is around 42 patients, they have correlated that with the MMT-8 with time tests such as 30-second rise from chair test, 30-second 1 kg arm lift, and 2-minute walk distance. And they found that the p-value was significant in patients overall and those who had inactive disease. And the 2-minute walk distance correlated even in those patients who had disease which was inactive. And they also found similar correlation of the FI2 with the MMT-8. So these time function tests have good convergent and divergent validity, and they could be useful to assess muscle power and endurance as an alternative, especially in younger patients. And out of these, which 2-minute walk test served most parameters. If we talk about the next important index that we use to monitor disease activity, it is muscle enzymes. AST, ALT unfortunately are less sensitive than CK in most disease subsets, but one category we must remember is in juvenile dermatomyositis, where ALT and AST serves better. Aldolase is not universally available, but in case of normal CK levels, it is the best and muscle-specific laboratory test to be used. However, you must remember 2 scenarios. That is CPK rise always a flare? No. These are the numerous causes where an asymptomatic hyper elevation of CK could be there. And also disease flare with normal CPK. We know it happens in several categories of dermatomyositis. Other reasons could be suppression of creatine kinase released by prednisolone, presence of creatine kinase inhibitors, and extensive muscle atrophy. Talking about other inflammatory markers like ASR and CRP, generally they're seen in patients who have arthritis, ILD, or cancer, especially the antisynthetase syndrome category. Ferritin, as we all know, serves as an important marker in patients who have progressive ILD with anti-MDA5 positivity. And very importantly, an elevated CRP in the setting of myositis should always raise suspicion about an infection. And we should check for CRP in patients who are at risk for ILD and cancer, such as older age, dysphagia, cutaneous infarcts, etc. So this was these are 2 important papers which I found where correlation of antibodies has been found to disease activity. So this paper assessed the levels of anti-Jo in around 80 patients, and where they found that there was a correlation, which was a longitudinal follow-up also it was seen, where lung VAS and muscle creatine kinase levels were seen. And there was a modest correlation between several components of the MITAX VAS, which assesses extramuscular disease activity. So it did correlate modestly with muscle and joint disease, and a significant correlation in a small subset of patients who were followed up longitudinally. This paper was published a little later, and where it's shown around 11 patients who had MDA5 positivity and rapidly progressive ILD, and most of the patients who improved from active disease, who went into remission, did show that their levels touched the cutoff which they had defined for inactive disease. Coming to MRI, of course, we use that as diagnosis, but it can also be used as follow-up, and the specific sequences like a T1 weighted could show us damage evaluation. There's something known as a fat fraction mapping, which is done on T1 weighted sequences. a fat-suppressed T2, which could again help us identify what is the response to therapy. Even the stir sequence does the same. So this is an example of how we can see before and after therapy the changes that we can see in a T2 fat-saturated and a T1 fat-saturated after IV gadolinium enhancement. These are some biomarkers which are being studied. Again, we do not use them routinely in clinical practice, so I will not spend much time here, but this probably is prospects for the future, which we are looking towards, and we can see we're targeting all different cell populations, right from a pan marker like IL-6 to T-cell, myeloid markers, interferon signatures, and there have recently been a lot of papers on focusing on CXAL9 and 10. The myositis-specific autoantibodies I briefly did touch upon, and also levels of anti-SRP and HMG-CoR have been found to correlate with disease activity, especially patients with very high levels of CK necrotizing myositis. So trying to assess patients, how do we assess them? At initiation of therapy, and depending on immunosuppression, the first visit usually we plan at 2 to 4 weeks. We can assess the the muscle enzymes monthly for the first 3 months, and then once every 3 months till the disease is controlled. Also, it's worthwhile doing MMT-8, physician and patient global VAS, which we can do in clinical practice as well. HAC, again, depending on availability, we can do, and these muscle enzymes can be checked upon. Extramuscular disease activity will come to in the subsequent slide. We have scores which we can do, again, which are VAS-based. A patient with ILD scenario, which we often encounter, we can use a 6-minute walk test, but again, this gets confounded because of patient having concurrent muscle weakness. We can repeat it at 6 months, and also imaging depending on what is the response to treatment. A very important monitoring is needed, that is for the drug-related adverse effects and probably any complications or damage we are acquiring because of the disease or the drugs. So for this, when we monitor the patient, the targets we are trying to achieve is a remission, which could be both off medicines and on medicines, and predominantly a clinical remission. Disease flare, again, if we do get worsening by 20% in 2 of the 6 core set measures, which includes MMT-8, muscle enzymes, function, and also extramuscular disease component and many others. So a common dilemma that we are faced is whether it's activity or whether it's damage, and all the parameters which I've discussed till now, right from muscle strength, endurance, muscle enzymes, MRI imaging, muscle biopsies, and EMGs, these can always help us differentiate between the two, because this is a very common question we are faced at follow-up. A change in treatment is definitely warranted if a worsening muscle weakness is seen at 3 months or when we try to taper steroids. And if we see that the improvement in MMT-8 is less than 20%, it's worthwhile changing the immunosuppression and checking for compliance. And at any time point, a new onset clinical manifestation which might require different immunosuppression might warrant a change in treatment. So to conclude, I have tried to encompass the various measures of disease activity here into this diagram, where clinically we have muscle strength, physical function, and endurance. CMAS is something which is relevant for juvenile dermatomyositis, so I didn't really elaborate on it much. But again, it's a little cumbersome to do. Patient-reported outcomes, again, very important. We need to speak to the patient how he's feeling, which includes global disease activity, physical function. Laboratory includes muscle enzymes, MSA, and inflammatory markers. Imaging, like I talked about, on inflammation and fat fraction. And of course, extramuscular, I'll conclude with this slide, where we can do NFC to see vasculitis and follow up for GIT involvement, cardiac parameters, which we can see, which we can do with all of these. The assessment of ILD, cutaneous, we have scores. So extramuscular evaluation is quite elaborate, and we can take help of these various parameters, and composite measures are available for the same. So thank you. IMAX has links for all of these parameters which we can use, right from HAC to an MMTH, which we can use. Thank you.
Thank you, Dr. Anu. I've been asked to add a few words to what you said, and I would like to add by saying that it's a beautiful overview on what biomarkers, and it's not just related to measurements in the lab, but also in the clinic. But the biomarkers which would be relevant to you in the clinic would be on different heads, like markers which would prognosticate, for example, which would predict the presence of a cancer in the patient. So some of the antibodies like the TIF-gamma would predict the presence of cancer. So these sets would be a set of biomarkers for prognostication. And your MMT-8 examination is very universally known. The timed function tests, I would suggest that I would like to use them in patients who have already reached a particular level of improvement, because gross improvement in a functionally poor patient is very obvious. But when we start worrying is when the plateau is reached, when we have started the steroid taper, and we don't really know whether the residual weakness is damaged or it can be improved further by continuing the steroids. So a CMAS is a great instrument for the pediatrician, and I wish we had something like that for adults. because that would be an extension of the timed function test. Thank you very much.
Thank you.
We have Hot Topics 2022 update on myositis classification to be presented by Dr. Vinita Jova from Bangalore.
Good afternoon, everyone. At the outset, I would like to thank the organizers of this meeting, Dr. Dhanda and the scientific committee for inviting me for this important session. And I thank the Iracon organizers. They have come up with these wonderful halls, and the ambience is just too good. Thank you very much for that. So straight away, starting with my topic, which has been allotted to me, update on myositis classification. I have slightly tweaked it to spend next 10 minutes or so to tell you where we might be headed in next couple of years. I have no disclosures pertaining to this session. We are all very much aware that inflammatory myositis is one of the very, very heterogeneous clinical disorders, and yet it has highly specific manifestations in muscular and extramuscular organs. It also has several distinct clinical phenotypes, serological associations, and histological features with unique prognostication. Therefore, it is of paramount importance to have a classification criteria to create well-defined, relatively homogeneous cohorts. This also helps us to pin our hat on a diagnosis at times. So this picture depicts what I'm trying to say, the heterogeneity, but this is how we would like to see it through the classification schema. And we are making efforts to reach there. We are not there yet, as I will show you in the next couple of slides. Several classification criteria have been developed since 1970s for inflammatory myositis, all with different emphasis, and based mainly initially on clinical or muscle biopsy features, and later on expanding to involve serological characteristics. Over the past 15 years, we have seen an increasing number of criteria being proposed. However, most of these criteria still have several limitations, as is very evident from this image that this is very much a work in progress. The EULAR ACR classification criteria for adult and juvenile inflammatory myositis was developed after many, many years of deliberations and was a result of dedicated efforts of experts in not only adult rheumatology but also pediatric rheumatology, the neurologists, the dermatologists, epidemiologists, as well as the biostatisticians. Importantly, this classification criteria for the first time guided us towards a subgrouping as well. So what did we gain from this classification criteria? This was, for the first time, very, very data-driven classification. It used a web-based calculator, and it categorized patients into definite, probable, and possible based on a score and corresponding probability of the disease by using 16 variables, and it was also having a high sensitivity and specificity. But what was missing? Several groups of myositis could not be classified by this criteria, especially for us rheumatologists, overlap myositis. That was something which we could not classify using this, and so were some deficiencies in recognizing antisynthetase syndrome. Even though the initial data collection had included 5 myositis-specific antibodies, however, only anti-Jo1 autoantibody had significant number of observations to derive in the to be participating in the analysis and inclusion in the classification criteria. The several other limitations included that the data originated largely from the Caucasian population, so it needed validation in other population. Further, it included patients with at least 6 months of disease duration, so could be truly applied at the time of initial presentation. Immediately after the publication of myositis classification criteria, several groups across the world tried to validate it in their cohorts, and so did we. Our group also compared this criteria against the Bohan and Peters criteria in our longitudinal myositis cohort involving 111 patients. We had almost the entire spectrum of subgroups, and but we unfortunately found a rather weak agreement between the Bohan and Peter classification criteria and the EULAR ACR classification criteria. The dermatological variables, which were somewhat of a challenge in our skin color, and a lack of availability of Jovan, which has a very heavy weightage of 3.9 and 3.8 with and without biopsy, were the possible reasons for this weak correlation. Also, in patients in whom the biopsy data was not available, and in the polymyositis subset, both criteria performed poorly. Another report from Dr. Lisa's group at NIMS also reported similar results in our country, and they further went on to suggest that it would be useful to expand the dermatological variables in the EULAR ACR classification criteria. And they also made a very important suggestion: addition of non-classic cutaneous findings at the node of the sub-classification tree could substantially improve the sensitivity of the criteria for subtyping patients of dermatomyositis, especially across different populations. Dr. Hector Chenoy's group looked at the relationship between the expert-derived and the EULAR ACR classification criteria, and in this report they included 255 consensus expert opined inflammatory myositis cases. They reported a high sensitivity of 99.6%, but found incorrect subgrouping in almost a third of the patients, and largely it was the patients with polymyositis who were being incorrectly subgrouped. This was more so in patients with inconclusive biopsies. In the subsequent publication, they included patients who were having non-Jovan myositis specific antibodies, and they had tested them by immunoassay, the Euroline immunoassay, and they tested for anti-HMG-CoA reductase by ELISA. And they showed that in 309 of such physician-verified patients with inflammatory myositis, in which 78 of those 309 had an alternative MSA. They gave the same weightage as Jovan to these non-Jovan MSAs, and they reported that the sensitivity for the classification criteria improved from 73.1% to 96.2% for definite inflammatory myositis. The number of patients who were classified in the original classification criteria as probable were 13, but with the non-Jovan MSAs included in the classification criteria, that number reduced to only 3. Now this informs us that there is an urgent need for expanding the MSA spectrum in the classification of inflammatory myositis. Another interesting observation was made by Professor Maman's group at Johns Hopkins. And one of this team's objective was to predict clinical phenotype based on the MSAs, and it looked at their 2,475 patients. They included 524 patients who were positive for at least a single MSA. In their study, they found that EULAR ACR criteria successfully classified 91% of their MSA positive myositis patients. However, they found that the patients who were positive for SRP, PL7 or HMG-CoA reductase were being misqualified. In myositis patients with MSAs group, the autoantibodies were found to outperform the EULAR ACR defined subgroups to predict clinical phenotypes. Now, based on these results, authors developed a simple set of criteria to classify patients based on the presence of MSAs. They validated this in their own cohort as well as in an external cohort from Spain as well. So in this, they said that for MSA positive patients, to classify a patient as inflammatory myositis, it is sufficient to have MSA plus one of the following, which is muscle weakness, creatinine kinase elevation, ILD, arthritis, Gottran sign or papules or heliotrope. But is clinico-serological classification enough? What about the seronegative patients? They form a large proportion of IIM patients. In our own cohort from Myoin Society, including which included data from 3 centers, and we had 150 patients analyzed in this study, the seronegativity rate was about 1/3. So what about them? How do we go on to classify them if we are going to bank on only the serological classification? And what about patients with dual positivity? We frequently come across patients who are positive for 2 of the MSAs. In that situation, what would we use? In our own study, we found that dual antibodies were seen in about 1/5 of the patients. And we also had a very small number of patients who had more than 3 antibodies. So this is another daunting question. So MSAs, the picture is fuzzy and the categories are not so well defined. So this is what I learned from our own MSA data analysis, that these clean, well categorized cohorts, what we see in the images across in the articles, in the review articles, based on the MSAs, they may be quite blurred in our population, and this may not be a true reflection of what's happening in our country. So where are we headed? Apart from the integrated clinico-seropathological approaches, can we look at some other modalities? 2 days back, Professor Ingrid had shown us strong associations between HLA alleles and autoantibody specificities in Caucasian patients with IAM. I'm not going to delve into that part, but can MRI of the muscles help in teasing out these groups better? So in this recent report from Japan, the radiologists used image analysis. They called it as texture analysis of muscle MRI, and they did machine learning based classification. So using this technique, they could quantify the image characteristics based on distribution of pixels and their surface intensity of pattern. The image characteristics which were analyzed in this automated analysis or in this machine learning based analysis were microstructures of the background tissue which may be imperceptible to human visual system. And interestingly, they included patients with myositis as well as non-IM patients, and they suggested that this technology, this methodology has a potential as a method for predicting disease groups or even autoantibody status in patients with IAM. Even though the numbers which they analyzed were small, they did say that it has the potential to predict the status of anti-Jo1 and other anti-ARS antibodies. So this is very, very exciting. Can machine learning also help us to classify our patients better? So in this study, they use unsupervised machine learning, and they use the data which was available from the RIM trial. They use similarity network fusion to clinical and biological data on these 168 patients. So using this similarity network fusion, they identified 5 patient groups, and autoantibody enrichment defined 4 of these groups: anti-Me2, anti-SRP, anti-NXP2, and anti-synthetase. Depletion of IgM defined the 5th group. And this is exemplified in this picture. Each group was associated with one subtype. Adult DM was associated with anti-Me2 and anti-synthetase. Juvenile dermatomyositis was associated with anti-NXP2, and adult polymyositis was associated with anti-SRP and IgM depletion. Patient groups rarely overlapped with other subtypes, as enriched associations encompassed at least 61% of each group. To sum up, myositis classification is very much a work in progress, and it definitely requires expanded autoantibody inclusion. The subgrouping must include all groups of myositis, including overlap and antisynthetase syndrome, possibly by adding categories at the nodes of the subclassification tree. MRI protocol standardization as well as standardization of the detection of MSAs would probably help in cleaning up this classification criteria, though there may remain several lacunae such as seronegative patients and dual positive patients, which will require further teasing out. My personal feeling is that the single classification criteria may not be the best fit for for this very heterogeneous disease. Thank you very much.
Thank you, Dr. Vinita, for your presentation. So now we have the keynote lecture, Update on Myositis Management, to be presented by Dr. Ingrid Rodenberg from Sweden.
How do I get the slides up there? So, good afternoon, and first of all I would like to thank the Iracon Scientific Committee for inviting me to your really fascinating, fantastic meeting. It's an honor to be part of your faculty and your discussions. So these are my disclosures, and this afternoon I would like to discuss with you the management of myositis, and I will start with some introduction. Now we already had that, but I will do it briefly, and then discuss treatment overall, and also treatment in specific clinical presentations of myositis. And finally, I want to emphasize the role of exercise in our treatment of myositis. So, as we have heard from our previous speaker, the myositis is a heterogeneous group of diseases, and based on clinical and histopathological features, we have these classical subtypes: dermatomyositis, polymyositis, inclusion body myositis, cancer-associated myositis, and juvenile dermatomyositis. And as also has been discussed, this is not only a disease of the muscle and the skin, but other organs are frequently involved, as you know, such as the lungs, the joints, and even the heart. And as you know, there has been a great advancement in myositis over the last decades. Has been this discovery of several autoantibodies that are specific for myositis, and they are helpful in the diagnosis, but also to subgroup patients with different phenotypes and different prognosis. And the largest group is the antisynthetase autoantibodies that are typically characterized by muscle weakness and interstitial lung disease. In the dermatomyositis patients, we have 5 autoantibodies, and 2 of them, NXP2 and TIF1 gamma, are associated with cancer, and the anti-MD5 with the lung involvement. We have 2 autoantibodies that are anti-SRP and anti-HMGCR that are associated with severe myopathy, often dysphagia, and they're called immune-mediated necrotizing myopathy. There is 1 autoantibody associated with inclusion body myositis, the CN1A. And in our group, we have identified an autoantibody called FHL1 that is targeting a muscle-specific protein, and that's also associated with severe myopathy. In addition to these myositis-specific autoantibodies, we have the so-called myositis-associated autoantibodies, as they are also present in other autoimmune diseases like Sjögren and lupus. And these can be found either as monospecific in myositis or in combination with the myositis-specific, such as the RAW52 or the PMSCL. And they are also identified with certain clinical phenotypes. So now, based on these clinical, serological, and histopathological features, we have now 3 additional clinical subgroups: the antisynthetase syndrome, the immune-mediated necrotizing myopathy, and the clinically amyopathic dermatomyositis, which is dominated by the skin. And as a former speaker emphasize, we should not forget that we have a large group that is still classified as the seronegative. So when we talk now about treatment, then a first overall goal is to improve function and health-related quality of life. And in all patients also we want to eliminate inflammation and prevent damage. And for most of the patients with myositis, it's important to restore muscle strength and endurance, as we heard from the first speaker. And for some patients, it's to restore lung function. For others, it's to eliminate rash in the skin, and then also to eliminate arthritis. So there are a few randomized controlled trials that have been performed in myositis. So recommendations that have been published are mainly based on case series, case reports, and expert opinion. And in this review by Dr. Odis and Agarwal that I recommend you for reading, the authors here, this is one way to recommend treatment, and this is based on studies that have been mainly published with the old subgroups, the poly and dermatomyositis. And so excluding the inclusion body myositis, this is a recommendation algorithm to start as a first-line therapy with glucocorticoids in combination with an immunosuppressive agent like methotrexate or azathioprine. If the patients don't improve or don't tolerate, then we can switch to mycophenolate mofetyl or tacrolimus or cyclosporine. And there is one small study suggesting that combination of methotrexate and azathioprine could be an alternative. And as a third-line therapy, we have biologics, rituximab, cyclophosphamide, or other biological agents. And at all three levels, there are some indications for high-dose IVIG. Now, based on this treatment recommendation, most patients, although we use these high doses of glucocorticoids and immunosuppressive drugs, many patients only have a limited effect. So there is a high unmet need to improve treatment. And we want to postulate that we may move forward by identifying the different subsets, as the different subsets may benefit from different interventions. And with this, I want to now present one recently published paper on the subgroup dermatomyositis. So this was published in New England just a few months ago. And this is a trial using intravenous immunoglobulin. It's a randomized, double-blind, placebo-controlled phase 3 trial, the PRUDERM trial. And in this study, adult patients with dermatomyositis were included if they had active disease, and the treatment that was given was high-dose IVIG, 2 grams per kilo body weight every 4 weeks, up to 16 weeks. And the primary endpoint here was the proportion of responders defined based on the myositis response criteria of at least minimal improvement, and that's 20 points. And for this trial, 95 patients were included and randomized to IVIG or placebo. And this is the major result. As you can see at week 16, which was the time for the primary endpoint, there was a significant improvement in the IVIG arm, with 48% reaching the primary endpoint versus the placebo were at 21%. And at the same time, the total improvement score in the active treatment was almost 48%, in the placebo 21%. And then in the open label extension phase, the placebo group was switched to IVIG, and after 40 weeks, they almost reached the same frequency of responders. And this is actually the first randomized placebo-controlled trial where there is a successful improvement, where we can see them reaching the primary endpoint. So the conclusions from this trial is that high-dose IVIG may be a treatment option in patients with refractory active dermatomyositis, and Octagam has now been approved for dermatomyositis by FDA. Of course, this is not a solution for everyone because there is a limitation both due to the high cost and also to availability, as we have experienced during the COVID pandemic. Now I want to discuss another subgroup or clinical problem in patients with myositis. That's patients who have myositis and interstitial lung disease. And this is common in patients with dermatomyositis and polymyositis, and in particular in the antisynthetase syndrome, up to 90% may develop ILD. And in the subgroup with anti-MD5 autoantibodies, it's up to 75%, so higher frequency in Asian population. And in this subgroup, the ILD can be rapidly progressive. And it's also important when we discuss the criteria and definition of disease that some patients with the myositis autoantibodies may have ILD as their first and only clinical manifestation of myositis. And also the ILD goes with high morbidity and mortality. And in the same review by Dr. Odison Agarwal, they also present an algorithm for treatment of patients with ILD in myositis. And they divide the patients into those with mild to moderate lung disease and those with severe disease. And the recommendation in those with mild to moderate interstitial lung disease is to use an induction therapy with steroids, either oral or IV as a pulse therapy, and then also include immunosuppressive treatment, mycophenolate mofetil or azathioprine as first line, or tacrolimus or cyclosporine as second line. And in refractory cases, rituximab or cyclophosphamide or other combinations. And in the severe disease, on the other hand, they recommend to start with pulse intravenous glucocorticoids in combination with cyclophosphamide or rituximab. And then after 3 to 6 months to follow up with maintenance therapy similar to the mild to moderate disease. But if the patients don't respond to this first induction therapy, then there is a possibility to combine rituximab and cyclophosphamide, although you have to be aware of the risk of infections. Now, if patients still don't respond, other possibilities are like abatacept or agents that are being tested in clinical trials. So then where should we be alerted for the severe interstitial lung disease? Well, in this large multi-center cohort from Japan, the investigators found that risk factors for severe lung disease were age at onset over 60 years, presence of the anti-MD5 autoantibody, but also elevated CRP, which we don't so often see in patients with myositis, and a low oxygen saturation. So I think now we have some good news because there haven't been any trials published on treatment, controlled trial and treatment of interstitial lung disease in patients with myositis. But this study was just published this month in Lancet Respiratory Medicine and was published by the principal investigator and presented at the ACR. And this, I think this makes a major contribution now in the area of ILD and myositis. So this was a study, a multi-center trial from UK of interstitial lung disease in patients with connective tissue diseases, including systemic sclerosis, mixed connective tissue disease, and myositis. And at the ACR, Dr. Mayer presented data from a subgroup analysis of the myositis outcome. So in this study, they compared rituximab versus cyclophosphamide. And the primary endpoint was the rate of change in forced vital capacity between baseline and 24 weeks. And patients that were included were those that have signs of ILD and where these types of drugs would have been clinically indicated. And this is the major result concerning myositis in this study. And here we can see the change of forced vital capacity in the cyclophosphamide arm and rituximab arm. And the primary endpoint was at 24 weeks. And as you can see, the one positive result is that in both arms there was an improvement that was significant, and there was no significant difference in the effect by the cyclophosphamide and rituximab arm. But the side effects were numerically fewer in the rituximab arm. So again, there is a possibility to use both of these drugs, and I think you need to have individual, take the individual profile into your decision here. So to summarize the management of interstitial lung disease, I would recommend you to all to work with your pulmonary physician. And we should use induction therapy with tight monitoring and follow the pulmonary function tests in the beginning every 3 to 6 months, or more frequently when indicated, and repeated HRCT when clinically indicated, for instance, absence of improvement or worsening, also to exclude infections. In the subgroup, which is rare but still very challenging, the patients with rapidly progressive interstitial lung disease. Here we should be aggressive in the induction treatment and tight monitoring. And ECMO may be indicated for the patients to improve or to before lung transplantation. And you should also discuss possibility of lung transplantation early concerning these cases. So then I move on to the next group, a special case, the patients with immune-mediated necrotizing myopathy. So there are 2 autoantibodies in this group, the anti-SRP or anti-HMGCR autoantibodies. And this subgroup of myositis is characterized by often severe muscle weakness. They often have dysphagia and they are difficult to treat. The anti-HMGCR positive may be associated with statin treatment. So if they are on statin, you should stop the statin. And then start treatment with prednisolone in combination with methotrexate or azathioprine or mycophenolate mofetil. And evaluate the patient with muscle strength test, as we heard the first speaker here. And after 2 to 3 months, if patients haven't improved in their muscle function, you can consider adding rituximab, which has been reported, at least in some case series, to be effective in anti-SRP positive patients, whereas in the anti-HMGCR positive patients, there are case reports or case series suggesting that high-dose IVIG may be beneficial. And something that I really want to advocate is to include exercise in the treatment. There have now been several controlled trials suggesting that exercise in patients with myositis is safe, also in the early disease, so start as soon as they can, do some exercise. It's effective to improve strength and fitness. And also it has an immune modulating effect and reduces inflammation and fibrosis, and it can increase capillary density. So it's an important complement to pharmacological therapy, but it should be individualized, and the optimal training still needs to be defined. So to summarize, myositis is a complex disease, and management in this multidisciplinary team is important. And we should move towards individualized treatment according to the clinical and serological phenotype. And importantly, the immunosuppressive treatment needs to be combined with the physical exercise. And we need to identify predictive biomarkers for treatment response, and we need to have new therapies, and for this we need to collaborate. And I think you have a fantastic large network that could contribute to knowledge in this area. And I invite you to join our international collaboration, the MyoNet register, where we can do collaborations on large cohorts, and this register you can also use to follow your patient in the clinic. And finally, I would like to acknowledge my colleagues at Karolinska in the myositis group, but also in the immunology, in the lung clinic, and my international colleagues that we have been working with, I've been working with for many years. So by this I want to thank you. Thank you.
Yes. Thank you, ma'am, for your rich presentation. Now, we are a little ahead of schedule. We are in a position to take a few questions.
Am I audible? Yeah, I think I'm audible. We have talked about the treatment of inflammatory myositis. Is there anything new for inclusion body myositis? Because the results are very, very poor. And I got 3 patients who are disappointed with me because of that.
I would say the most important information that we have gained on inclusion body myositis management is that exercise can help. We can actually improve strength with very heavy strength exercise. Pharmacologically wise, we don't have any good news. Rapamycin may be effective, but what we may expect from the pharmacological treatment may not be improvement of strength, but to slower the progression. But exercise is beneficial.
Thank you. Nothing new we got. Anyway, I forgot to introduce myself. Darshan Bhakuni from Delhi.
So you're not audible.
It is on. We find that patients with PMSCL, most of them we can identify clinically on the bedside before antibodies are. But there is a distinct subgroup of PMSCL who are identical to antisynthetase syndrome, in so much without any scleroderma changes. In fact, we have 2 sisters. One had classical synthetase syndrome, including mechanics hand, and another had typical PMSCL scleroderma myositis overlap. Both had PMSCL antibodies. So this distinction between myositis specific, that is synthetase is a myositis specific antibody, it has so many CTD features like interstitial lung disease, arthritis, it is a CTD. And then PMSCL is included in the myositis associated. So this, isn't these distinctions kind of arbitrary? On the other hand, we have a spectrum.
I'm not sure that I got the whole question. Maybe I understand that the myositis autoantibodies are not as distinct as they sometimes are presented. I totally agree with you.
Especially the PMSCL is, it's arbitrary to include in an associated.
So, yeah, the PMSCL, some patients have the only myositis clinical features, whereas others have more the scleroderma overlap. I totally agree with you. And I think we need the whole spectrum of autoantibodies to define our myositis subgroup. And that's what I presented on the other day in the course, because we see that also the myositis-associated autoantibodies contribute to the subgrouping. Definitely, I agree with you.
Rajkiran from Hyderabad. This is for Professor Ingrid. A couple of questions, ma'am. What is your advice in managing calcinosis and ulcers in these patients? And the second question is, where do you position tofacitinib in this management of myositis?
I'm not sure.
Calcinosis and ulcers.
Yeah.
It's a position of calcinosis and ulcers. Where do you place tofacitinib?
Oh, yeah. Thank you. Calcinosis is a very difficult manifestation to treat. There is today no clinical study that has shown any beneficial effect. There are individual case reports, for instance, of abatacept in children with calcinosis. There are a few studies now coming out, open label studies on JAK inhibitors with beneficial effect, in particular on the skin. So I think that may be a new way forward, but I am not aware of any studies that have addressed specifically the problem with calcinosis. Maybe someone else here in the panel is knowledgeable on this.
I am Dr. Narsimlu from Hyderabad. Madam, then some case reports are there, calcinosis responded to MAPTHERA. And even I also my experience, nearly in the last couple of years, 5 to 6 patients, scleroderma calcinosis, they did respond to, some completely, some partially. So MAPTHERA maybe drug of choice. JAK inhibitors, I recently started few patients, to see the results. But there is again case reports of JAK inhibitors effective in polymyositis.
Yeah, YK from Singapore. If I may, I would like to follow up on the question. Hi, Professor Ingrid, good to see you. And about the JAK kinase inhibitor. I think a group of us in Singapore, especially with the anti-MDA5 myositis with rapidly progressing ILD, have seen pretty good results with the JAK kinase inhibitor, be it tofa, baricitinib, or UPA. So I was just wondering, what is the experience in Europe? In fact, there has been some case report, and I see, especially in India at this meeting, that there are many generic tofacitinib which cost a fraction of the price of what the original drug is. So are there trials that are ongoing, and what are your thoughts and your experience on the use of JAK kinase inhibitor, especially in the MDA5? It works for the skin as well. Thank you.
Yeah, thank you. I remember when I visited Singapore that you had success with 1 or 2 cases, and then there was this report from China where they used JAK inhibitors as first-line treatment for MDA5 positive patients with very impressive effects. I'm not aware of any studies ongoing in ILD or anti-MDA5 positive disease with or without ILD on JAK inhibitors, in particular for the lung or MDA5. So, but I think it's very promising based on its effect on the interferon, which seems to have a role in this subset of, so it will be very important if you can publish your case series, which then may encourage more people to use it. And I agree with you. I've seen the JAK inhibitors here in India. There are several of them, and that may be another alternative to rituximab or cyclophosphamide. And I thank you for this comment.
Can I ask a question? Ma'am, do you think tofacitinib would be a better alternative, or baricitinib would be a better alternative? Both of them are little different in the terms of their JAK inhibition.
Yeah, I don't know. I think we have, but of course it's important with the side effects, which we may choose. So, but we have no experience in our own clinic.
Ma'am, a question about the classification. So Vinita in her talk said that she would love to see overlap myositis included, find a mention in the classification criteria. But I think there is some reason behind not including it. So what's your thoughts about this?
Yeah, thank you for discussing. I really appreciate that, because that brings me to announce that we are going to revise the criteria now. But what is also important to mention is that, as you already told us, that the EULAR ACR classification criteria were based on cases. So we had overlap myositis, and we used different statistical methods to identify possible new groups, but the data didn't give us the overlap myositis. So they were included, but they didn't come out as a special subgroup. Maybe if we have more cases now, But the important now when we are going to revise and validate the criteria is that we have good comparator groups where we have all the clinical but also the serological data from many other diseases, both from the more muscle diseases, from the neurology department, derm diseases, and also, of course, rheumatic diseases.
We'll take this as the last question, sir, because of time. Okay.
Thanks for the excellent talk. Praveen Hisaria from Adelaide. I had more of a comment actually. We keep talking about myositis-specific antibodies, and it's absolutely fascinating with the way it's possibly going to change the way we look at myositis, and it's being included now in the criteria. My point is that the elephant in the room when we talk about myositis-specific antibodies is the detection system. The validation of the blot, which is the commonly used method for detection, and this is across the board, I think not just India, is actually flawed in itself. The cutoff that has been published actually are not cutoffs. They are based upon only one antibodies, and I think there is going to be, we have to have horses for the courses approach, which is to have different cutoffs for different antibodies. And we've recently have done a study, we've not published it yet, about using the cutoffs for different antibodies. And for example, PL7, even 42 is not a cutoff based upon the blots. And I guess that's where it comes in when we talk about these multiple antibodies being positive and what to do about them. And I think we have to separate the wheat from the chaff and address this elephant in the room, which is what do we define as a positive myositis-specific antibody on blot when we are going to define diseases based upon its presence.
That's a very important point you have raised, Dr. Praveen. Actually, myself and Lisa, while we were dissecting out the data for Mayo in Society, we thought that we should look at the cutoffs. We used 2+ and more as significant. But there were many of them which were 1+. So we were not sure as to what should be the right cutoff. And actually our next step is to look at to identify as to what would be the right cutoff, whether it should be 1+, 2+, 3+, or something else. Because we were not happy with dual antibodies, which we saw in about 20% of our patients, and that was a real surprise to us.
Yeah, that was my point actually. And there'll have to be, you can't have 2+ for everything, as I was telling. For example, as I said, PL7, maybe even 3+.
This is what we found. So we are going to work on it.
It'll have to be different for each one. And now the blot has about 13 antigens, which makes it even more complex.
This was 16 antigen, right?
Yeah, I think, but there are differences between the specificities also. Like TIF1 gamma has a low sensitivity with the line blot, whereas, for instance, SRP may have a high sensitivity. And I think you need to regard them based on the individual specificities, and also in the clinical context, of course.
So are you proposing that we should use different formats for testing different antibodies?
Well, I think that would not be practical, but I think you have to look at them carefully in the clinical context, and also we need to validate them more in larger cohorts.
Right, thank you.
And also with healthy individuals and higher diseases.
Thank you. So in the interest of the time, maybe we can have the last comment. And
I wanted to sound an alarm caution about using jackanapes. This, especially MDA5 is associated with CMV, right? CMV, and we don't generally use jackanap. We have had patients who have been given tofacitinib and then they develop CMV pneumonia. So this this is also maybe one reason why rituximab also strongly activates CMV, and it can happen within a week. So poor outcomes of rituximab in MDA5 may be related to CMV activation. So this is something people should be concerned when they are using jackanap. Second, there was a comment on calcinosis. We should consider calcinosis is damage, which means there is tissue damage which is resulting in calcification. So we should be targeting activity by whatever means. This is something, we should be focusing on treat. So but one thing, if the new calcinosis appears, that means new damages happen which has caused calcification. So even whatever treatment we use to control that. Again, one question I have for Dr. Ingrid is this: how much of the seronegative are truly seronegative after doing a immunoprecipitation assay? How much is a detection problem? How much is truly?
Have you lowered the percentage of seronegative? Our percentage of seronegative in our cohort when we have used we have combined immunoprecipitation and line blot, ELISAs. We still have about 40% that are seronegative, including the HMG-CR antibodies. So we believe that there are yet autoantibodies to discover. You have unknown bands, but those that are totally seronegative may have another disease.
So thank you all, and I would like to close the session and thank all the speakers and the audience for making this session a very interactive session and dissecting the myositis. Thank you all. But I would request you all to stay seated, and we are going to have the great debate of the day and perhaps of the Iracon. And for this, I would like to invite Dr. Rohini Handa. Sir, please come on the dais to take it further. And if I take your permission, sir, contextually I recollect one of the quote from my senior professor and your colleague, Dr. R.N. Srivastav, who was basically retired from AIIMS and was doing nephrology. And in one of his orations, I heard that cyclophosphamide was his favorite poison. So let's have this debate. Over to you, sir.
Sessions finish, and before we get started with the mother of all debates, because I think there are concurrent sessions going on in the other halls,